from Iowa.
Thank you very much, Mr. Chairman, for allowing me to waive on to this critically important hearing. And thank you for moving my cost-saving PBM reform legislation, the Drug Act, favorably through your
last year.
Line.
Why can't you provide
I just came back to the company, so I'm.
Let me also
your medication?
From Iowa.
be a middle.
People are dying because they can't afford their medication, and you all are part of the problem. I yield back.
Chair now recognizes Ms. Miller-Meeks from Iowa.
Thank you very much, Mr. Chairman, for allowing me to waive on to this critically important hearing. And thank you for moving my cost-saving PBM reform legislation, the Drug Act, favorably through your committee earlier this year. Let me also just add on to what my colleague just said and who's responsible for high prices in prescription drugs. And I'm going to add that government is also responsible for that in some of the legislation that we put forward. It's no secret that PBM middlemen artificially inflate the cost of and limit access to prescription drugs. My first attempt at PBM reform was as a state senator when I passed a bill in 2019 trying to get at transparency of this marketplace. This occurs at the expense of patients who receive health insurance in public and private markets and impacts patients of all ages. The PBM market has become highly consolidated, with the three largest PBMs controlling roughly 80% of prescriptions. The top 6 PBMs account for 97%, and in Medicare Part D, 4 PBMs manage benefits for a combined 90% of beneficiaries. PBMs claim that they reduce drug prices by holding pharmaceutical companies accountable. This is done by requiring rebates on drugs, which are then passed on to the beneficiary. But is that beneficiary the patient? While PBMs often do negotiate discounts from manufacturers, patients are not the ones who benefit from them. In Medicare Part D, for example, patient cost sharing is based off the list price of drugs, which are artificially inflated by the PBMs to extract a higher rebate. As a result of these practices, for 79 of the 100 most rebated drugs in Medicare Part D, beneficiaries pay more for the drug than their insurer, again demonstrating that beneficiaries, in this case seniors, are not benefiting from rebates. This is why I led the bipartisan Share the Savings with Seniors Act, which would require full rebate pass-through for chronic care drugs covered under Medicare Part D plans. Another way PBMs cut cost at the patient's expense is by limiting the number of treatments available on formularies, despite claims by PBMs that they promote access. In 2022, 1,156 medications were excluded from at least one of the 3 PBMs, CVS, Caremark, Optum, RX, and Express Scripts, from their formularies, which represented a 961% increase in excluded products from 2014. This is not a partisan issue. Every American who utilizes prescription medications experiences the impact that PBMs and vertical integration have on our healthcare system. And let me also say that my mother had Express Scripts. And for me, there are some benefits that PBMs actually help to provide. However, this is partially why, and this is why that the Federal Trade Commission, because of this vertical integration, which currently comprises our Federal Trade Commission more Democrats than Republicans, is investigating the harmful impacts of middlemen and the vertical integration. Chair Khan of the FTC stated in recent interim report that dominant pharmacy benefit managers can hike the cost of drugs, including overcharging patients for cancer drugs, and that PBMs can squeeze independent pharmacies of many Americans, especially those in rural communities that depend on essential care. In Iowa, for example, 25 independent pharmacies have already closed this year, and I met with Hy-Vee, which is a grocery retailer that also has pharmacies. They're in 7 states. They're closing 2 pharmacies. And so if you have a multi-state company or national companies that cannot keep pharmacies open because of the cost and reimbursement, or reimbursing lower than what it cost a pharmacy to acquire the drug, these independent community pharmacies will close and are closing. When the FTC testified in front of the Energy and Commerce Committee earlier this month, the witnesses confirmed that your companies have not been complying with document requests. And that was true of my first bill in Iowa. We were supposed to have data within a year. It took 3 years to get data that was already in the possession of the PBMs. If your companies are so convinced that they can lower drug costs and increase access to innovative treatments for patients, you should be eager to demonstrate and not withhold information. Patients in my district are getting squeezed at the pharmacy counter and are seeing access to life-saving medications restricted. This is why I'm actually proud to lead these multiple bills to reform the drug pricing landscape to ensure PBMs and insurers are actually helping patients. Questions to any of you three. Many experts recognize that misaligned incentives in the current payment system have led to PBMs to favor medicines with high list prices and larger rebates or discounts. However, when your companies faced exposure over this rebating practice, PBMs have shifted their compensation models to focus on administrative or other fees, which have typically remained tied to list prices. So even in the cases where PBMs are passing most of the rebates back to health plans, PBMs still have an incentive to favor high list prices. In doing so, the current PBM compensation model is causing patients to face a higher financial burden for their prescription drugs. In my view, PBMs should not tie their compensation to the price of a medication, especially a percentage of the medication. That seems counter to your stated mission of lower drug costs. Don't you agree, Mr. Joyner? Agree or disagree?
So we've actually introduced a biosimilar at a low list price. So we do believe that introducing products at a low list price is actually beneficial for our customers and the patients in the PBM.
Thank you, Dr. Cosner.
Congresswoman, we have been on the record for years of employing drug manufacturers to lower their list prices and continue to do so.
And Dr. Conway?
We want manufacturers to lower their list prices.
I would like PBMs to have a reduction in the amount of a drug that they're putting into the billions of dollars that are in this marketplace, and we'll continue on the PBM reform that I've started on. Thank you so much, Mr. Chair. I yield back my time.
Thank you.